even though I've trained as a rheumatologist, I'm a little more of a pain researcher than a OA researcher. We do a fair amount of OA research, but mainly looking at the effect of nosoplastic pain, a term you heard earlier today. So I was asked to talk about other outcomes that could be used long-term in these studies. And so just very briefly, these are the types of things I'm going to talk about, but I'm really going to focus on some of these objective assessments of function, either performance-based measures or activity-based measures, because the other things have really been talked a lot about by the other speakers. But just a little bit of context. The first thing I want to point out is when you talk about assessing an individual's pain versus their function, I think it's important to think of pain as more of a state and function as more of a trait or a behavior, because that's really the way they act when you study them. Pain often changes very rapidly, but in most studies of analgesics, whether we're talking about a drug, a surgical procedure, or whatever, there's a fairly large subset of individuals in whom you can relieve their pain quite a bit, but they don't have corresponding improvements in function. So function is really more sort of a series of habits that people have gotten into with respect to what they can do, what they think they can do, and that doesn't change as rapidly as pain. So when I talk about some of these objective assessments, there's really two ways that have been used in OA. One would be, and David Felson's written about this, a lot of people have written about this, I think this is a good idea, that you have some type of objective assessment of performance based on doing a certain activity, and then you could add a measure of pain when you ask individuals to perform that task. The other thing you can do is, if you will, watch individuals as they're functioning in their day-to-day life using something like actigraphy, and I'll talk about that. But first, give a little background. If you haven't used actigraphy, you probably won't know this. And first is, what is the relationship between the self-report and the objective measures of physical function? And the answer is not very good at all. And it doesn't matter if we're looking in OA or any other disease, quite frankly. If you look at average activity levels, and then you look at sort of a PRO measure of functional status, there is from a non-existent to a weak effect between those measures. They really are not measuring the same construct at all. And I just show you some data really quickly, a study we did several years ago in fibromyalgia, the poster child for nosoplastic pain, but I think everyone knows that fibromyalgia patients are incredibly dysfunctional, that on average, on measures like the SF-36 or some of the newer PROMIS measures, they'll score 2 standard deviations below the mean in activity levels. But when you put an actigraph on individuals, I want to just emphasize that these are the kind of data you're going to get. You're going to get like these little bouts of activity. And I want to come back to this because you can either measure average activity, the average number of steps, or you can measure the bouts of activity that occur here. And these are quite different with respect to what they relate to. So the first thing you see here is look at fibromyalgia patients. In spite of the fact that their physical component summary score, the SF-36, if you will, an older good measure of overall function, was 2 standard deviations lower. They were almost identical in actigraphy measures. I mean, really couldn't have been closer with respect to their average activity level. But all is not for naught. If you actually look at their peak activity level, they differ quite a bit, as does the variability of peak activity. So if you see this graph here, you see there is quite a difference between the peak activity level of fibromyalgia patients and those of healthy controls, the fibromyalgia patients being down here, the healthy controls being up here. And there also actually is a much better correlation between the PROs of functional status and the peak activity levels on an actigraph. I like this study. This is a study that was done several years ago to look at if you combined the WOMAC and an actigraphy-based measure, could you get better discrimination potentially? And this study suggested perhaps, this is a small RCT really looking primarily at whether adding the actigraph would be helpful. And the study suggested that it would be, even though this study was small, and that potentially a combination of an actigraphy-based measure and a pain or functional status PRO might be more discriminative than either of those individually. If we think more broadly, should we expect a strong relationship between these self-report and objective measures? No. Whether you're measuring the objective versus subjective correlates of sleep, or the objective or subjective correlates of memory or cognition, you always see what we see between functional status measured objectively and measured subjectively. So I really want to emphasize that these are separate domains, and they really tell you different things about how well that person is functioning or how well they're able to perform some of these tasks. This is a nice study that really looked at a broad range of potential outcomes and the degree to which these outcomes were different in OA patients versus controls. And I think some of these activity-based measures here, some of the, again, measures where you actually ask someone to perform a task and see how much pain they have or how much they can actually do, or again, actigraphy-based measures that are more so peak activity measures would be in play with respect to considerations about what would be the better measure. And this is always a question that people ask, given the differences between the self-report measure and the objective measure, which is the right measure. I don't think either of them is right. I really think they measure different things, and a composite or an aggregate measure would probably give you a better overall sense of how that person is doing than either of those measures separately. And so again, I'm going to put this is my last slide, my money down that some combination of the above is going to end up being a lot better. And I will say, as someone who's been doing functional brain imaging to measure pain for about 2 decades, I think functional MRI can measure pain objectively, but I don't think we know yet that we could use it in the way we're talking about here. Certainly we could talk about that in the question and answer session. Thank you.